Hello, everyone. My name is Mona Kacher, and I am hosting this PSI webinar today jointly with my colleague Russell Jones. The topic of our webinar today is causal inference, and some of you may think that's a somewhat new topic to our world of pharmaceutical statistics and may wonder what the motivation for this was. So just would like to say a couple of words about that before then introducing our speakers. So I guess all of you are well aware that the ICH E9 addendum, the draft was published in Europe a couple of months ago. I think that it was published in the US this week. And the ICH E9 addendum, so the draft, actually brings causal reasoning besides maybe just randomization and ITT into our world of pharmaceutical statistics, or at least that's one way we can interpret some of the concepts laid out in the ICH E9 addendum. So in this webinar, we therefore thought it would be very interesting to discuss the link between the ICH E9 addendum and causal inference. So we'll have a presentation on that. And then we'll also talk about some additional causal inference ideas around, for example, principal strata estimands and per protocol estimands. So in terms of the agenda for today, we will have 3 speakers. So in total, we have 2 hours, 3 speakers who will provide us different perspectives on this topic. For your information, the first 2 presentations will be made available on the PSI website, and you have the link on the bottom here. So the slides as well as the recordings will be made available. Yeah, just for information. And then, of course, you will also be given the opportunity to ask questions after every single talk. And for that, I'd like to just remind you that you are muted for the whole webinar. However, you have the opportunity to write your questions into the question box, and the questions will then be noted during the presentation and will be put to the presenter at the end of the presentation. So we have allowed for around 5 to 10 minutes after every talk, so there should hopefully be plenty of time for us to have a lively discussion. Now, before introducing our first speaker, I would just like to put a plug for additional PSI events and webinars that are upcoming. For more information, I suggest that you go to the PSI webpage, but here you have already a list of some of the events that are upcoming. So I would like to draw your attention in particular to those that take place soon. So in November, I'm sure there are a couple of topics that are of interest to all of you. And then in addition, there is actually a pre-conference course for our conference in Amsterdam, so in June 2018, which is very much related to the topic of today's webinar. So it is on demystifying causal inference, will be given by Ian White and Sabine Landau. So if you're interested in the topic today, then I'm sure you'll be also very keen on attending this course. So with that being said, I would like to go back to the slide with our presenters and would like to introduce our first presenter, Professor Dan Sharfstein from the Johns Hopkins Bloomberg School of Public Health. Dan is a professor for biostatistics, and he joined the department 1997. Prior to that, he received pre- and postdoctoral training from the Department of Biostatistics at the Harvard School of Public Health. And his research is focused on how to draw inference about treatment effects in the presence of selection bias. And as you may imagine, so some of his topics of interest include missing data topics and causal inference. And some of you may have heard of his name also in the context of the National Academy of Science document on the prevention and handling of missing data, as he was one of the panel members there. So without further ado, I would then like to hand over to Dan, who will talk to us about Estimand and causal inference. Dan, could you please unmute yourself in case you're still on mute?
So good morning, everybody who's in the United States, and good afternoon or good night for other people who are in other parts of the world. Today I'm going to talk about estimands and causal inference. And okay, so if any have any questions, you can always contact me at my email address, dscharf@jhu.edu. Right here. So just as by way of disclosure, I regularly consult with pharmaceutical and device companies. I sit on DSMBs, mock advisory panels, consult on data analysis and study design, provide training, and have been involved in litigation. I served on the National Academy panel that issued the report, The Prevention of Treatment of Missing Data in Clinical Trials, and I've received funding from NIH, PCORI, and FDA for the development of statistical methods and associated software having to do with missing data in clinical trials. So I want to acknowledge two colleagues, Miguel Hernan from Harvard University and Michael Hudgens from the University of North Carolina, who graciously shared some of their course material with me on causal inference. And so in the first part of this course, I've borrowed heavily from some of their course materials. So thanks to them. So what's an estimand? An estimand is a population parameter that quantifies the effect of treatment relative to control. In the National Academy report, there's a section on estimands where it is discussed as a target of inference in a randomized clinical trial. It's a quantity that's causally interpreted, and I think it was part of the motivation for the new ICH addendum. The ICH addendum specifically avoids the word causal, but it uses the language of causal inference. For example, it uses a phrase such as, what would have happened to the same subjects under different treatment conditions? And that's exactly the language of causal inference. So while they don't use the word causal, there's clearly, they're thinking about causal inference. So causal inference is a mathematical language for defining causal estimands, and it's also a language for formulating what we call identification assumptions. What kind of assumptions do you have to make in order to learn about these causal estimands from the observable data? And it's really an extension of the standard mathematical language that we use in statistics, which is really focused on looking at associations. So in terms of the outline of my talk this morning, I'll talk about an intuitive definition of cause. I'll provide a mathematical formalism. I'll talk about individual level causal effects, population level causal effects, the difference between association and causation. I'll talk about randomized experiments and in their ideal form, and then talk about intercurrent events, which is something that is discussed heavily in the ICH addendum. And I'll give examples of 4 or 5 estimands, and then make some comments for discussion, and then open it up for your questions. So let's consider a situation where we have a patient, Ian, and Ian took a red pill on September 1st, 2015. And then 5 days later, Ian died. Okay, so he took the red pill, then 5 days later he died. But if we ask the question, had Ian not taken the pill, okay, so had Ian not taken the red pill, everything else being equal, 5 days later, he would have been alive. And the question is, did the red pill has a causal effect on Ian's death? And I think most people would say yes, everything else was equal. He took the red pill, he died. If he didn't take the red pill, then he would have been alive. Jim, alternatively, did not take the red pill on September 1st, 2015, and 5 days later, he was alive. And then had Jim taken the red pill, okay, so all other things being equal, he also would have been alive 5 days later. question, did the red pill have a causal effect on Jim's death? Since everything else was equal, and the only difference is that he did not take the red pill, and then had he taken the red pill, he'd have the same exact outcome, then the answer would be no, there was no causal effect of the red pill on Jim's death. So when we, as humans, we often compare mentally the outcome when action A is present with the outcome when action A is absent, all other things being equal. If the two outcomes differs, we say the action has a causal effect, and this action A is often referred to as an exposure or a treatment. So in order to mathematically set up a framework, I want to introduce some notation. So we're just going to think about a binary treatment, okay? Either get it or you didn't, and a binary outcome, you either lived or died. And so I'm going to define A to take on the value 1 if an individual is treated with the red pill, and I'll let A equal 0 if individual was not treated with the red pill. And so in this case, Ian, he took the red pill. He was observed to take the red pill, and so for him, AI is 1. And Jim did not take the red pill, and his AJ is 0. I'll define Y, which is the outcome, live, die. So the outcome Y is 1 if the individual dies, and the outcome Y is 0 if the individual lives. And so for Ian was observed to take the red pill, and Ian died 5 days later, so his YI is 1. And Jim did not take the red pill, and 5 days later he was alive, so YJ is 0. So in terms of the observed data, we can make a little table for Ian and Jim. So and that's summarized at the bottom of the page. So Ian has A, he was exposed, he took the red pill and he died, and Jim did not take the red pill, so his A is 0, and he lived, and so his Y is 0. So when we talk about the causal inference and its mathematical formalization, we talk about 2 additional variables, and which are called potential outcomes. And so for each individual, we define their outcome treatment and their outcome under no treatment. So we have an outcome Y0. So Y0 is 1 if the individual dies if untreated. So we're talking about Y0 is we take on the value 1 if the individual dies if untreated, and Y0 will equal 0 if the individual lives if untreated. So in this case, Ian, if he had not taken the red pill, he would have lived, right? And Jim, if he had not taken the red pill, or in this case, we know he took the red pill, had not taken the red pill, he lives as well. So for Ian and Jim, they both live under no treatment. Similarly, you can define potential outcome under treatment, which is Y1 will take on the value 1 if the individual dies if treated, and Y1 will equal 0 if the individual lives if treated. In this case, we know that Ian would die under treatment, so his YI1 is 1, and Jim would live under treatment, so his YJ1 is 0. So now we can make a new table, which is depicted on the bottom of the screen for Ian and Jim. So A and Y are in the second and third columns are the observed data for Ian and Jim, and then the last 2 columns refer to these potential outcomes, the Y0 and Y1. And so in the case, again, for Ian, he lives under no treatment but dies under treatment, and for Jim, he lives regardless of what treatment he received. They're both a 0. And the boxes that are shaded in blue, in purplish blue, those are these potential outcomes, but they're not observable. So I don't observe Ian under the treatment that he did not receive. Okay, so I don't know the Y0 for Ian, and I don't know the Y1 for Jim. Okay, God knows those, but not we don't see them based upon the observable data. So in terms of individual level causal effects, so there's a causal effect for Ian because he has different outcomes when he takes or does not take the red pill. So those potential outcomes are different than one another. Jim, however, has no causal effect, right? Because his outcomes are the same regardless whether he takes the pill or not. And so the individual level causal null hypothesis is that the potential outcomes are the same under treatment and under no treatment for every single individual. That would be what's called the individual level causal null hypothesis. And it's something it's not testable. So sometimes we use the word potential outcomes. Sometimes you hear the word counterfactual outcomes. So one way I think about it is the potential outcomes are Y0 and Y1, both these guys. And what's really one of the take-home messages is we think about Y0 and Y1 as being fixed attributes of the individual. They're just like your genes, okay? They're just like baseline covariates in a clinical trial. They're just fixed attributes of you. How you would, whether you would live under no treatment and whether you'd live under treatment. Those are kind of fixed attributes. So that's a really important aspect of causal inference. So what's the difference between a counterfactual outcome and a potential outcome? Is a counterfactual outcome is the outcome under treatment that you did not actually receive. So it's really those blue boxes. If we go back, these are the counterfactual outcomes because they're the outcomes I don't get to observe. It's the outcomes under the treatment I did not receive. So if I received A equals 1, so if I was observed to take the red pill, then the outcome under no treatment would be counterfactual, be counter to fact. And if I don't take the red pill, then the outcome I would have under taking the red pill is counterfactual. Okay, so there's another assumption that in the causal inference literature, which is called the consistency assumption. And so here I've written a formula on the top of the page, okay? But basically this formula says that if A is 1, that is, if I'm observed to take treatment, then my observed outcome is equal to my outcome under treatment. And if I don't take treatment, okay, so I don't take the red pill, then my observed outcome is my outcome under no treatment. And that's what this formula says. It just picks off, if A is 1, it picks off Y1, and if A is 0, it picks off Y0, and it just connects it to my observed outcome. So it connects the potential outcomes to my observed outcome. There are a number of ways that treatment could have been assigned, but all those ways would have resulted in the same outcome. So there is a couple of articles that I think are important to look at, a paper by Cole and Frangakis, and another paper by Vanderweel and Hernan that talk about that there's actually meat to this assumption, the consistency assumption, and it basically says there's one version of treatment, and there could be many ways in which treatment got assigned to you, but every single way that treatment was assigned would result in the same outcome. But I just refer you to those papers if you want to get into that. So, so the observed data. So this is just now expanding the table down to some more people. Here we observe for Ian, took treatment, he died. So we basically we observe Y1 for that patient by the consistency assumption, and we don't observe Y0. Okay, so Jim did not take treatment, he lived, so we observe Y0, and it's 0 for that guy, but we don't know what his outcome would be under treatment. Ken took treatment, he lived, we observe Y1, which is that he lived under treatment, but we don't know the Y0, etc. So this just connects the observable data to these potential outcomes. So individual causal effects cannot generally be determined, except if you have some crossover experiment in which you make very strong assumptions. And the reason is because I can't compare for Ian what his outcome would be under treatment versus his outcome under control because of these question marks. I can't compare this 1 to this question mark because I don't know the question mark. I can't compare this 0 to this question mark because I don't know the question mark. So I can never, except if you make some strong assumptions and do some kind of crossover experiment, learn about individual level causal effects. So some people have thought of causal inference as basically a missing data problem because I don't know those question marks. Another really important bit about causal inference is that what we're interested in learning about in this context is the proportion of individuals. So this probability statement here is the probability that y of little a is 1, right? And I'm going to vary a will take on the value 0 or 1. And so what I want to know is what's the proportion of individuals in the population who would have developed the outcome, who would have died, had everyone in that population received treatment little a. So I want to know if everybody had received treatment little a, what fraction of people would die. And that's the language used in the ICH addendum. And another important aspect of causal inference is that this is a marginal probability, okay? It's a marginal probability. What if everybody in the population had been treated with had taken the red pill? What fraction of people would have died? What would be the proportion of people who would have died if everybody had not received the red pill? It's a marginal probability because it's referring to the entire population. It's not a conditional probability. Okay, so a population, in contrast, a population level causal effect, okay, is that the proportion of people who would die if everyone had received treatment is not equal to the proportion of people who would die if everyone had not received treatment. And that would say that there's a causal effect at the population level, okay? The population level causal null hypothesis is that these two marginal probabilities are equal to each other. And you can measure causal effects on many different scales. You can take a causal risk difference. So you can compare these, take the difference of these two proportions. You can take a ratio of these two proportions, or you can create an odds ratio. So look, now the question is, can I identify these causal effects from the observable data, right? Because these causal effects are written in terms of these potential outcomes, but that's not what I don't observe the potential outcomes for everybody, right? So the question is, can I identify, can I estimate them from the observable data? So identification means that the quantity of interest, that is these proportions that are described in terms of potential outcomes, can they be determined? Can I write down a mathematical formula from the distribution of the observable data? And population level of causal effects can be identified under no assumptions if we have a randomized trial which has ideal features, and I'll talk about this later. So what's the difference between what I just described in terms of causal effects and association? So in contrast, when we talk about association, we're talking about a conditional probability. So the probability of dying among people who were observed to take treatment little a, okay? So this is the proportion of people who develop the outcome, die, among those who receive treatment little a. And it's a conditional probability. We're not talking about every single person receiving little treatment A. We're just focused on the cohort of people who actually were observed to take treatment little a, okay? It's a conditional probability. We say that treatment A, capital A, and outcome Y are associated if the proportion of people who die among those who took treatment little a, who were observed to take treatment little a, is not equal to the proportion of people who would die who did not take treatment little a, and then we say that they're associated. And we say that they're not associated or independent if these two conditional probabilities are equal to one another. And just for simplicity, I use the notation with this little perpendicular sign. This means that A is independent of Y. And you can measure associations on many different scales, right? You can take a difference in conditional probabilities, you can take a ratio of conditional probabilities, or you can form an odds ratio, okay? But the key distinction from what I described previously is that we're talking about conditional probabilities, not marginal probabilities. So association measures difference in risk between disjoint subsets of a population, right? Because we're talking about the people who actually received treatment A versus the people who received, who did not receive treatment little a, right? I apologize, sorry. So association measures difference in risk between disjoint subsets of the population determined by individuals' actual treatment, what they actually were taking. Causation measures difference in risk in the entire population under two different treatment values. So that's the key distinction between association and causation. And Miguel Hernan has this nice picture that tries to illustrate this. So we have our population of interest. They have segregated themselves into people who were untreated, that's the white box, and people who are treated, that's the gray triangle here. And association basically just compares the proportion of people who die in the white sliver, the untreated population, to the proportion of people who die in the gray sliver, treated people. So that's a contrast between the gray and the white slivers of the proportion of people who die. In contrast, causation is asking the question, if everybody in this square, if everybody, the people who were actually untreated and the people who were treated, right, if they had not received treatment, what would their probability of dying be? Versus everybody in this box, the untreated and the treated, right, if they had received treatment, what fraction of people of them would have died? Okay, so it's comparing the same subsets of people, right, everybody in this square, in contrast to association, which is comparing the proportion of people who die in disjoint groups. So statistics and causation. We need potential outcomes and counterfactuals to talk about causation. I realize there are some people who may argue that you don't need that. I find it very helpful personally. Other people argue that maybe it's not needed. Statistics is a language of association, not a causation, and causal concepts can't really be represented purely in terms of statistical language. We need these potential outcomes to think about causation. For example, if you look at a formal definition of confounding, you really need to introduce the notion of potential outcomes, and confounding occurs when the proportion of people who die, had everyone been treated with treatment little a, is not equal to the proportion of people who die among those who were observed to take treatment little a. Okay, so in order for us to talk about causation, we needed to introduce this other notion of the potential outcome to actually have a formal definition of confounding. So now let's talk about, I'm going to move towards randomized trials, and let's talk about an experiment and a randomized experiment. So an experiment is a scientific study in which an investigator intervenes in the assignment of treatment to individuals participating in the study. We also know this is a clinical trial when the goal is to study effects of medications or devices in humans. A randomized experiment in which is when the assignment mechanism is essentially a random procedure like a flip of a coin. So in the idealized randomized experiment, you might expect to be no loss to follow-up. People fully comply with their assigned treatment. There's one version of treatment, and then you have double-blind assignment. Neither the study participants nor the investigators know who's receiving which treatment. So this might be, think of this as being the ideal randomized experiment. In the ideal randomized experiment, right, treatment assignment is independent of all your baseline characteristics, probabilistically guaranteed, right? That treatment is independent of the traits of the individual, right? And that's why I argued that I said that these potential outcomes are traits of the individual. And so just like any baseline covariate, right, treatment is independent of these potential outcomes in the ideal randomized experiment. So if that's the case, then, and the consistency assumption holds, says that I can learn about the causal quantity of interest, that is, the proportion of people had everyone received treatment, the proportion of people who die had everyone received treatment, that's this marginal probability, is actually equal to the conditional probability, that is the proportion of people who die among people who actually receive treatment, who actually randomized to treatment one. That's the beauty of the randomized trial, is that I can learn about the distribution of the potential outcome from these conditional probabilities in the randomized experiment. Similarly, I can learn about the proportion of people who would die had everyone in the population not received treatment by estimating it as the proportion of people who die among people who did not receive treatment, who randomized to the control group. And it's because of this independence assumption that we get an ideal randomized trial. The key thing is that the individuals in the treatment groups are exchangeable. The people who actually receive treatment are just exchangeable with the people who did not receive treatment by the randomization process. Importantly, this does not mean that treatment assignment is independent of the observed outcome. In fact, they're actually, they can be related to one another, right? But this assumption here is not the same as saying that A is independent of the observed outcome. In fact, we expect it to be related in trials where treatment is effective. And so that's another really important point. Okay, so now we're going to move towards intercurrent events. And so the ICH addendum talks about intercurrent events. And examples of intercurrent events is, say, after randomization, people initiated rescue medications, or people switched from one treatment to the other, or people stopped taking treatment. And the question is, how do I define causal effects in the presence of intercurrent events? And so I'm going to focus the rest of my talk, and I have about, I think, if I'm not mistaken, about 15 more minutes, and talk about the example of rescue medication. Suppose that some individuals initiate rescue medication prior to the time of their outcome assessment. Okay, everything else is the same. Everything else is ideal. There's no loss to follow-up. But some patients initiate rescue medication prior to the time of their outcome measurement. And so I'm going to introduce some notation to deal with this rescue medication example. So A will be our treatment assignment, okay? And then I'm going to define a potential outcome that relates to the use of rescue medication. So R of little a will be the use of rescue medication under treatment little a. Okay, so had you been assigned to treatment little a, had you taken assignment treatment little a, what is your use of rescue medication? And R is equal to R of capital A is the observed use of rescue medication. So this is a potential outcome because it happens after treatment, okay? And it's what your rescue medication would be under treatment little a. This is your observed use of rescue medication. Then I'm going to define a potential outcome, but now I'm going to index it by two quantities, both your treatment assignment and your use of rescue medication. So Y of A comma little r will be your potential outcome under treatment little a and rescue medication use little r. Y of little a, your potential outcome under assignment A, is actually can be written as Y of little a comma capital R of little a. That's your outcome under treatment little a, and Y of capital A is your observed outcome. All right. So what I'm going to observe in the trial are going to be A, R, and Y, but I've introduced these potential outcomes, R of little a, Y of little a comma R, and Y of A. And I've illustrated this on the next page. So here's an example. Here's Faye. Faye did not take treatment, did not use rescue meds, and was observed to die. Okay, and here, what do we learn? So I've now written in the last sets of column all these potential outcomes. So what can I observe here? So Faye did not take treatment. She did not use rescue medications. So I know I know R0 for this for Faye, and it's 0. She did not use red. I don't know R of 1 because she did not take treatment. I know her outcome under no treatment and no rescue medication. She dies. I don't know any of these other potential outcomes. I know her outcome under no treatment, which is dying. I don't know her outcome under treatment. And so you can see this, the rest of this figure here tells me, here's my observable data in the first, second, third, and fourth columns, and then these are all the potential outcomes. So under randomization, what I have is that my treatment assignment is independent of my potential outcomes because they're just traits. So A is independent of R of A, and A is independent of your death outcomes under treatment little a and rescue medication little r. So now, with the introduction of these potential outcomes, we can now define a whole host of estimands. And so I'm going to talk about 6 of them, but I may have to preempt because of time. But I'll start with talking about the intent to treat estimand, the hypothetical or prescriptive estimand, the hypothetical natural estimand, the principal stratification estimand, composite, and per protocol effect estimand. So what is the intent to treat estimand? So intent to treat, all we want to know is what's the probability of dying had everybody in the population been assigned to treatment 1, to treatment A equals 1, versus what's the proportion of people who would die had everybody in the population not received treatment? And so this measures the causal effect of being assigned to treatment versus control. You don't need to make any additional assumptions to estimate them because of randomization, but its interpretation of whether when we contrast these two quantities can be impacted by the occurrence of intercurrent events. For example, if rescue medication is effective and more patients on control initiate rescue medication, I might not see a difference between these two quantities, but it could just be because everybody in control, couldn't tolerate it. I'm sorry, everyone in control, there was lack of efficacy, so they stopped taking the control medicine and they initiated an effective rescue medication. So I don't see a difference between these two numbers. But it's completely driven by the asymmetric use of rescue medication between the treatment and control group and the fact that rescue medication is effective. So some people don't particularly like this estimand in this setting. But an advantage of it is it doesn't require any assumptions, but its interpretation can be impacted by the occurrence of intercurrent events. So a hypothetical or prescriptive estimand is asking questions like, what would happen? What would happen? What would be the chance of dying had everybody taken treatment and been forced to take rescue meds? Versus, what would happen if everybody did not take treatment and was forced to take rescue meds? Okay, so the rescue medication use is kept constant between the two, right? And the only difference is their assignment to treatment. Or I can say, what's the chance of dying had everyone received treatment and did not take rescue meds, forced not to take rescue meds, versus what's the probability of dying had you not taken treatment and forced not to take rescue meds? Again, the rescue medication is kept the same, and the only difference is treatment assignment. So questions are, is this reasonable or ethical to intervene in this way by forcing people to take rescue meds or not take rescue medications? So that's a scientific question and an ethical question. So it's not really, can be in many senses not realistic. And it does require additional untestable assumptions. For example, saying that we have some kind of conditional independence given some covariates. So you're going to have to, in order, if you want to estimate this hypothetical or prescriptive estimand, you now have to be in a world in which you have to start imposing assumptions. Here's another estimand called the hypothetical or natural estimand, is that you intervene on the intercurrent event in the treatment group by setting the rescue medication use to its natural level under the control condition. So here what we're doing is they're asking the question, what would happen in a world in which, what would be the probability of dying in a world in which everybody received treatment 1, but you forced their rescue medication to what it would have been under control, versus what would happen in a world in which the chance of dying under no treatment and you set your rescue medication to what it is under no treatment. So again, you're holding the rescue medication the same between these contrasts, and the only difference is treatment assignment. Again, is it realistic or ethical to intervene in this way? And again, it will require additional assumptions in order to estimate this particular, to contrast these two particular quantities. Another estimand is the principal stratum estimand. So here we can contrast a whole bunch of different quantities. So the first one, I'm asking the question, among the subgroup of people, so this is like a subgroup analysis, okay, because it's based upon intrinsic traits, or like baseline covariates. Among the people who would not use rescue medication under either treatment or control, that's a subgroup, I'm asking the question, what's the probability of dying under treatment? Versus, again, the same subgroup, so I'm comparing apples to apples, what's the proportion of people who would die under no treatment? So that's a principal stratum contrast. Or I can say, for the subgroup of people who would not initiate rescue meds under no treatment, so this is the same, what's the proportion of people who would die under treatment versus the proportion of people who would die under control? And the last one is, what's the proportion of, so this is the subgroup of people who would use rescue medications under no treatment. It's the same in both these situations. And I'm asking, what's the proportion of people who would die under treatment versus the proportion of people who would die under control? Okay, and so these are called principal stratum causal effects. A problem with this particular one is that we don't know, right? We don't know necessarily what your stratum membership. If a patient walks into your office at the point at which you're making a treatment decision, you don't know whether or not they're going to be a person who would never use rescue medications regardless of treatment group. You don't know whether or not they're going to not use or not use rescue medications under no treatment. And in addition, it also requires additional untestable assumptions. One can create what's called a composite outcome. All right, and now you can merge the use of rescue medications and the death outcome into a composite. So I can define a new potential outcome called U of little a, which takes on the value 1 if you don't use rescue medications under treatment and you don't die. Okay, so if you're thinking like, well, the best outcome would be is you don't use rescue medications and you don't die, right? And so so it's a composite of both the rescue medication and the death outcome here. And you can ask the question, what's the proportion of people who would not use rescue medications and not die under treatment versus what's the proportion of people who would not use rescue medications and not die under no treatment, and contrast those. Well, a problem with this particular estimand is that it mixes the effect of treatment as a mixture of both its effect on rescue medication use and the outcome, and one might question its clinical relevance. The nice bit about it is that it's an ITT effect, but on a newly defined outcome, and it doesn't require any additional assumptions. So the last estimand, I think I have about 5 more minutes, is called the per protocol effect estimand, and this is a recent New England Journal paper that was written by Miguel Hernan and Jamie Robbins. It just came out probably about a month ago. I encourage you to go look at it, where they talk about the per protocol estimand. So suppose the protocol just prescribes, suppose you write in your protocol that says, if you have a specific interrecurrent event V, then it's okay to use rescue medication. Otherwise, you're not supposed to use it, Okay, so the protocol is specifically saying you have a particular event, then go ahead, use rescue medications. But if you don't have the event, then we prohibit the use of rescue medications. Now, further, suppose some patients use rescue medications when V does not occur. Suppose there's non-compliance, okay? So I'm going to define an outcome Z of little a, which basically says if the intercurrent event occurs under treatment little a, then the outcome that we're interested in is your outcome under treatment little a and the use of rescue medications, because that's what the protocol says. If V of A is 1, then I want you to be using rescue meds, okay? And if V of A is 0, I want to know what's your outcome under treatment little a, but you're not supposed to use rescue medications. And so what I want to do is now compare what's the proportion of people who would die under treatment 1 under following this protocol, right? So Z of 1 is 1 versus what would happen, what's the proportion of people who would die under no treatment, okay? Assuming that they follow the protocol in a world in which the protocol was followed. So this is not the same as the hypothetical, because we're not forcing everybody to take rescue medications. We're just saying that you should use rescue medications when a particular event V occurs. And it's not the same as the per protocol analysis. We're not just estimating the effect among people who followed the protocol. We want to know what would happen in a world in which everybody followed the protocol such that whenever they have an intercurrent event V, they actually take the rescue medications. And because of the non-compliance, it requires additional untestable assumptions. If there was no non-compliance, then you could estimate that without any additional assumptions. So the take-home messages that I'd like to share is that the Estimand should not be conditional, okay, on post-randomization events. You don't want to compare apples versus oranges. They should be marginal quantities, which apply to all patients or the population, or if you're doing subgroup analysis, it should be based upon pre-randomization covariates, which apply to the subgroup of the population. So you can think about the potential outcomes as being pre-randomization covariates, and that's where you get yourself into the principal stratum causal effects. The choice of Estimand depends upon context and perspective, and it requires close interaction between statisticians, clinicians, and decision makers in order to decide on what a proper Estimand is. And it may be that just one Estimand is not enough in understanding treatment effects. So you might have to impose, in order to really understand things, have to be able to use multiple Estimands to figure out what's going on. And that the sample size design is going to depend upon the choice of Estimand. The potential and the counterfactual outcome framework is a mathematical language for formalizing Estimands and ultimately understanding identification assumptions. Untestable assumptions beyond randomization may be required, and some may be so strong that you maybe want to rule out that Estimand. It's just like I might be interested in it, but just in order for me to learn about it from my observed data, it just requires assumptions that I just can't really get behind. And when assumptions are required, that's another bit about the ICH E9 document, is that your inference needs to be checked with a sensitivity analysis. So here's just the key players who have in modern history of causal inference: Don Rubin, Jamie Robbins, and Judea Pearl. Here are a bunch of references, which I'll hold on the screen for a second. There's a book by Pearl called Causality. Miguel Hernan and Jamie Robbins are writing a freely available textbook on their, which is available on their website, which I encourage you to look at. There's a book by Morgan and Winship called Counterfactuals and Causal Inference. Immons and Rubin have a book. Gelman and Meng have a causal inference book from a Bayesian perspective. There's a book by Rosenbaum called Observational Studies. And then there are blogs by both Judea Pearl and Andy Gelman that are worth looking at. And here's just a couple of discussion points that I think are worth thinking about. What are the relative merits of different Estimands from a regulatory perspective? And then, how are we going to operate in a world in which inference about some estimates is going to require very strong untestable assumptions, and clearly sensitivity analysis is going to have to be a big part of that. And how do you make regulatory decisions from sensitivity analyses, where you don't have one answer to the problem but multiple answers? So I'll stop here and take questions. Thank you for your attention.
Many thanks for your talk, Dan. And just a reminder to everyone, if you want to ask a question, please type it into the questions window and we will relay that to the speakers. So we have a couple of questions here. The first one is perhaps a bit controversial. Do you think that there's a missed opportunity in the ICH E9 addendum in not using the causal inference language and potential outcome framework to define the estimands? For example, there's no clear distinction between the natural and prescriptive hypothetical estimand. Also, there are several principal strata estimands.
Well, it's, because I was trained in the causal inference framework, I think it's a very, natural way to frame things. I don't know. It would be tough. There were no academics who sat on that committee. My understanding, it was formed by, it was a committee of people from pharma and from regulatory authorities. So I don't know the answer to that question, but I think people who work in the causal inference field need to read the addendum carefully and weigh in. And hopefully through a talk like this, you can see some of the connections between the causal inference literature and the ICH E9 document.
Thank you. And there's just one other question here, which is, can you give a specific example of an untestable assumption for a particular situation or analysis?
Well, take the principal stratum estimand, for example. Okay, so let me see if I can go back. I'll try to be quick. I know we're running a little bit behind. Well, take the example of non-compliance. Suppose you had a protocol and you had non-compliance with the protocol, right? We need to make assumptions about the people who are non-compliant. So a typical assumption is that we've measured all the confounders that predict whether or not somebody is compliant with the protocol or not. And if there are unmeasured confounders, we can't make precise inferences. So we'll have to do sensitivity analysis.
Great, thank you very much.
So I will, I think we want to move on. So I think I'll stop sharing my screen and change the presenter to Baldur or to Mona?
To Mona for now. Thank you very much, Dan, for a very interesting talk. Thank you. Maybe just to follow up on something that Dan said during his presentation. He mentioned a paper by Miguel Hernan and Jamie Robbins that was just published a couple of weeks ago. So here's the reference for those of you who can quickly look at it. And then I guess we move on to our next presentation. Our next presentation will be given by Baldur Magnusson. Baldur is Director Statistical Consultant in the Advanced Exploratory Analytics Group at Novartis. He received his PhD in statistics from the Cornell University in 2010. And some of his research interests include Bayesian statistics, dose finding, subgroup analysis, causal inference, I guess somewhat more recently. But he will talk to us today about causal inference, namely about using principal stratification to address post-randomization events, a case study. So Baldur, I will give over the control to you now. And we'll go on mute. Thanks.
Okay. Thank you very much, Mona. And hello, everyone. Good morning, good afternoon, depending on where you are. My talk is about a case study from Novartis, where we used principal stratification to address post-randomization events. It has to do with an ongoing project at Novartis, so I am presenting the case study a little bit abstracted, for example, not including details on the specific indication and the specific endpoints, but I hope it's an interesting talk nonetheless. So the outline of my presentation is as follows. I will start by providing a bit of context as to the problem at hand before defining principal stratification and how we use that to specify the estimand of interest. The analysis in this case was Bayesian, so I will give a brief glance at the Bayesian model before drawing some conclusions in the end. So the context here is that we were in a situation with a phase 3 study that had been randomized to active treatment or control. And the primary question in this study was, what is the effect of treatment on an outcome Y, which in this case was a type of disease progression outcome? So far, so good. Now, during the course of the study, patients might experience transient elevations of some symptoms that we'll call S. And it's known from the literature that the occurrence of these symptoms can impact the risk for observing the outcome of Y. So more symptoms might increase your risk of experiencing the outcome Y. And what we also knew beforehand and was subsequently confirmed in this trial is that the treatment itself has a strong beneficial effect on this symptoms S. So you take the active treatment and the rate of symptoms would go down. And so the question for this presentation is, how do we account for this symptoms S at the level of the estimand and the estimator? And so the answer to this question, of course, it depends on the scientific question of interest. And in our situation, we were interested in knowing the treatment effect on Y among patients for whom this event S is very unlikely to occur. So what do we mean by that? How do we reflect that in our estimand? And the approach we took, which is one you would have seen in Dan's talk, is to focus on the treatment effect in a subgroup of patients who would not experience these symptoms S regardless of treatment assignment. And you know, this is the principal stratification estimand that Dan talked about and is also discussed in the new ICH E9 addendum. Other analyses that are commonly done might imply other estimands. For example, if you say that the occurrence of this symptom S is irrelevant, you're essentially working with a treatment policy estimand. Maybe you do a subgroup analysis where you look at the effect in a population of patients without pre-study symptoms in some period of time. But this isn't so useful if pre-study symptoms is then not predictive of what might happen on study, and it also doesn't acknowledge the treatment effect on S. Another possibility, although certainly less advisable, is to look at the effect in the population of patients without on-study occurrence of S. Of course, this conditions on a post-randomization outcome that's affected by treatment, and we know very well that the estimate of the treatment effect on Y, the outcome Y, would not have a causal interpretation. You could, for example, if you censor patients when S occurs, you are in a sense obtaining an estimate of a treatment effect in a world where S would not occur, which is what we'd call hypothetical estimand, since in practice you can't forbid these symptoms from happening, you can't intervene on them. So all of these estimates might be appropriate in some situations, but none of them were appropriate for our particular example. So I'll now talk about principal stratification, and for this I use a little bit of notation, which should be quite familiar after Dan's talk. So we have S of Z as a symptom indicator under treatment Z, where 0 is placebo and 1 is active. So S of Z equals 1 for patients who would experience these symptoms S if they're assigned to treatment Z. Similarly, we have Y of Z as an outcome indicator for the primary outcome. So Y of Z equals 1 for patients who would experience the outcome if assigned to treatment Z. These are potential outcomes. So we know that every patient has a potential outcome for both treatment assignments. We also know that we only observe one potential outcome per patient, namely the one corresponding to the treatment actually taken. And we consider these as fixed attributes that are essentially baseline characteristics. And I will also use S and Y to denote observed outcomes. So in principal stratification, and in this example, what we did is we stratified patients as belonging to one of 4 principal strata: immune, doomed, benefiters, and harmed. So patients that are immune are the patients that would not experience these symptoms regardless of treatment assignment. The patients that are doomed are those that would experience the symptom regardless of treatment. Benefiters would only experience it on placebo, and harmed would only experience it on active. And so you can kind of depict this nicely in a 2x2 table. So we have the potential outcome for placebo here in the rows, and the potential outcome for active in the columns. So when they're both equal to 0, we're looking at the immune principal stratum. Now, of course, the principal stratum membership is not directly observable, since we only see one potential outcome per patient. So, for example, a patient on the active arm, so Z equals 1, with S equals 0, they would be in this column, which means they could be either immune or they could be a benefiter. We just don't know. But based on what I said in the beginning, we're interested in estimating a treatment effect in the population of patients who would not experience symptoms regardless of treatment assignment. You know that we're interested in the difference in proportions of the primary event Y, the outcome Y, in the immune principal stratum. This is the population of interest in our subgroup analysis. And so without further ado, we can simply write down the estimand of interest, or the principal stratum causal effect, which in this case is just the risk ratio of the probability of experiencing the outcome if treated among immune patients, divided by the probability of experiencing the outcome if untreated among immune patients. And this, in this case, we used a risk ratio, but this could of course be a risk difference or an odds ratio as well. Now, as we move forward to try and identifying the estimand, this is where it gets a little tricky, and we might need some further assumptions. In practice, as I mentioned, we don't know the particular stratum membership for any given patient. We only know, for example, or we only observe how many patients on control did not experience symptoms, so that's this margin. And we only know, for example, on active, how many patients experience the symptoms, so this margin. We only see the margins of this table, but the actual number of patients in each of these cells we don't see. So we need some identifying assumptions to link what we can observe to the estimand of interest. And one common assumption in principal stratum analysis is called monotonicity, which essentially blacks out the harmed stratum. And what this means is that a patient that does not experience the symptoms on placebo will also not experience them if on active. So S of 0 equals 0 means S of 1 must necessarily also equal 0. And conversely, a patient that does experience S on active will also experience them on placebo. That's equivalent statement. Now, I note that this is a substantive assumption. It's not a statistical one, so it needs strong clinical rationale because we can't really test it. But the benefit of making this assumption is that now we are able to classify some patients into a particular principal stratum. So, for example, a placebo patient with S of 0 equals 0, we know they must be immune because they can't be harmed. And a treated patient with S of 1 equals 1, they must be doomed. Of course, some patients remain that are not classifiable. For example, a treated patient that does not experience the symptom, so S of 1 equals 0, they'll fall in this column here, so they could be either immune or a benefiter. But monotonicity, together with, of course, the fact that we had a randomized trial, allows us now to estimate the principal strata proportions. So the proportion of doomed patients is simply estimated by the proportion of patients in the active arm who experience the symptoms. The proportion of immune patients is estimated by the proportion of patients in the control arm that did not experience the symptoms. And then the benefiter proportion, well, we know the strata have to sum up to 1, so the benefiter is just 1 minus the other 2. Okay, good. So we're able to estimate the strata proportions. Now let's see what we can do about the estimand itself, which you recall is the risk ratio, the probability of experiencing the outcome if treated in the immune population, divided by the probability of experiencing the outcome if not treated in the immune population. So the denominator is actually identifiable without any further assumptions. Randomization and monotonicity suffice, because any patient in the control arm that does not experience a symptom, we know they must be immune. So we know the immune population on the control arm. So the denominator is simply estimated by the proportion of patients that experience the outcome on the control arm among patients who did not experience the symptoms. So we get a check mark next to the denominator. But for the active arm, because S of 1 equals 0 could imply either immune or benefitor, the numerator is not identifiable without any further assumptions. We could, and we will in the next couple of slides, derive bounds on the numerator, which will lead to a range of feasible values for the estimand. One could also make further assumptions, of course, although we didn't do that in this case. So again, without any further assumptions, just using the law of total probability and doing some algebra, you can write the numerator in the estimand, that's this quantity here, and now I'm abbreviating immune with just the letter I, and the letter B here is the abbreviation for benefiters. So we can write the numerator of the estimand of interest in an equation here, where I have marked one quantity as an intercept, one as a slope, and then we have a quantity over here, which is the probability of experiencing the outcome among active, if treated in the benefitor population. So the so-called intercept and slope can actually be estimated from the data. For example, the numerator of the intercept, this is the probability of experiencing the outcome among active, immune, or benefiters. And that we can estimate simply by looking at the outcome proportion in the active arm among patients who did not experience the symptoms. The denominator of the intercept and both quantities in the slope are simply functions of the strata proportions, which we know we can estimate. So all of these can be calculated. The quantity on the right, the probability of experiencing the outcome among active benefiters, that cannot be identified at best. We can say, make a fairly useless statement, which is that it's known to be between 0 and 1, since it's a probability. But we can't say anything else based on the data. We could make further assumptions, for example, assuming it's bounded above by something or bounded below by something else, but we didn't do that in this case. So, but just from this equation, if you plug in some assumed value on the right, we can calculate the resulting value for the numerator of the estimand of interest on the left. And so that's what you will see here. So what we can do is we can calculate the numerator of our estimand for a range of values of the quantity about which we know nothing. And you see that here in this plot. This is just simulated data. So on the x-axis, you have the quantity on the right-hand side in the equation from the previous slide. It's this quantity here, which is not identified. So we can simply look at the range of possible values between 0 and 1. And on the y-axis, you have the resulting value of the numerator of our estimand, namely the probability of experiencing the outcome among active immune patients. We know the slope was negative, and if you kind of draw a reference line to where the denominator of our estimand is, you can see that, well, if this quantity on the x-axis is close to 0, then there is next to no treatment effect in the immune population. If the quantity on the x-axis is large, then there's a fairly substantial treatment effect. You can, of course, just calculate the range of feasible values for the estimand itself. And here I show that. This is based on the same simulated data as the previous slide. And the only change is that the y-axis is now the risk ratio. So moving from almost no treatment effect to a risk ratio of a fairly profound treatment effect. So this sort of illustrates that making only one assumption and relying on the fact that this is a randomized clinical trial we can already derive a range of feasible values for our estimand. But so far, we haven't actually carried out any estimation, and in particular, haven't done any quantification of uncertainty. It turns out that even with the lack of identifiability, which we have here, it is fairly straightforward to estimate the quantities of interest working in a Bayesian framework, which we did here using the programming language Stan. You could do your MCMC sampling using the equation we derived for the numerator of the estimand of interest. You could sample based on this equation, but the issue here is we have a negative sign on the right-hand side, so the right-hand side could end up evaluating to something negative, which makes no sense for the left-hand side because that's a probability. So it's actually preferable to code the likelihood directly. And here you have a sort of a simplified glance at the Bayesian model that was used. So we start by modeling the principal strata proportions, which are the pi immune, doomed, and benefiters. So pi immune is estimated by looking at the proportion of symptoms in the control arm. Pi doomed is estimated by looking at the proportion of symptoms in the active arm, and the pi benefiter is just the one minus the other two. For the outcome model, we know that the patients in the control arm that don't experience any symptoms, we know they're immune, so we can inform the parameter for placebo and immune patients simply by looking at the distribution of outcomes in this group of patients. The issue is on the active arm, S equaling 0 means you could be either a benefiter or an immune patient, which actually means that the natural way to model that data is to use a mixture of two Bernoulli distributions with the parameter corresponding to the immune population for active treatment, and the other Bernoulli distribution having a parameter corresponding to the benefiter population in active treatment. And the mixture weights are just the corresponding conditional probabilities of falling into each of the two principal strata. So you set it up like this, you do your MCMC sampling, and you get posterior distributions for the pi's and the thetas, and then we can summarize an estimate for our estimand of interest by examining the posterior distribution of the ratio of theta among immune actives over theta among immune placebos. In terms of sensitivity analyses, we obviously made an assumption here about monotonicity, which we can't test, but you could partially relax it, for example, through allowing the harm stratum to exist, but using a strongly informative prior to keep its proportion low a priori. And you could also explore various informative priors for the parameter theta benefiter active, which is a parameter about which we don't learn much in the trial itself. And I want to say a little bit about how we used covariates and dealt with missing data. Of course, as is the case in many studies, we had variable follow-up time, so not all patients had available data on S and Y in the time period of interest. And we dealt with this using standardization, which I think is a fairly known concept in causal inference. Basically what it means is we write a standardized probability of interest. For example, the proportion of patients that are doomed, we estimated by calculating this integral, where the integrand is the model that we actually fit in the Bayesian framework, and the integrator is the empirical covariate distribution. So you have here baseline covariates that we think are important, and we have a missingness indicator, meaning that our model is a model of symptom occurrence in the active arm, conditioning on some baseline covariates, using the patients that are available to us at this particular time point. And so once you calculate this integral, you obtain the
Sorry, just a second, Baldo. We can't hear you anymore, I believe. Can you hear me?
marginal estimate of the proportion of doomed patients. Looking at the data, so it must ideally be backed by I've just been informed by Muna that that the audio was lost for the last 30 seconds or so.
Yes, we can hear you now, sorry. Could you restart with the conclusions?
Okay.
Yeah, sorry.
Okay, sure, no problem. Okay, no problem. Apologies for that, technical difficulties. So yeah, let's see. Yeah, to conclude, I found the causal inference framework, and in particular the use of potential outcomes, was a very natural way of working in the setting to define the estimand of interest. Principal stratification is just one way that you can approach this type of problem where you have an intercurrent event that needs to be taken into account somehow. It's not the only way, and the appropriate choice really depends on the specific scientific objectives in the particular case. The assumption of monotonicity is of course critical, and I mentioned before, it's not a testable assumption, so it must ideally be backed by very strong clinical rationale. The Bayesian framework I find is very appealing in this setting because it allows us to model the principal strata proportions, which are parameters that are constrained to sum to 1. We're able to handle the lack of identifiability by using mixture distributions, and we can use prior distributions to encode our knowledge or lack thereof about certain parameters in our model. So I want to wrap up by acknowledging my collaborators, Dan Sharfstein, which you heard before, and then several colleagues at Novartis, Heinz, Frank, Sebastian, Nicola, Nikos, and David. And with that, I thank you very much, and I think we can take some questions. Thank you.
Many thanks for your talk, Balder. Just a reminder to attendees again that if you have any questions, please type them into the question window and we can relay those to the speakers. So we have a first question here. I'm struggling a bit with the statement that S of 0 and S of 1 are fixed attributes for a particular patient and that there is no unmeasurable within patient random variation. Can you help?
Yeah, that's a good question. I think when I was first introduced to the concept of potential outcomes, that was also something that I struggled a bit with. And I think, I mean, and I would welcome if Dan jumps in as well once I've given my answer. We think of these S of 0 and S of 1 as random variables in the sense that they vary between patients, but that within a patient they do not vary randomly at all. And I think that's thinking about it that way helped me understand it. But I also welcome if Dan wants to add anything to that.
Yeah, I think that's a reasonable response.
Okay.
Okay, thank you. And there's one more question. If understood correctly, this was a post hoc analysis, and the analysis is very interesting, but admittedly also requires quite a few assumptions and is complex. For a new study, could a different design be used that allows targeting the same estimand, but under fewer assumptions or less complexity?
That's an interesting question. And I'm not sure that I have the answer for it. I think in this situation, one of the problems is that it's hard to say before the trial what is the population you're actually interested in, because we don't really know beforehand which patients will experience these symptoms on study. So you have essentially a target population that's hard to identify at entry into the study. So I'm not sure whether we could design the trial in a way to maybe be able to pick up the right patients at the start. And I would have to say it probably depends on the specific situation. I think in this particular case study, it would have been very difficult to do that.
Just another question just to come in. If immunity, doom, benefitor are determined post-randomization, then there is potential misclassification due to dropout before we observe the immunity doom benefiter status.
Yeah, so I think if we go back to here, yeah, where I talk about standardization. So if you're absolutely right that the immunity, when we can determine principal strata membership, that is done using the post-randomization data. But we estimate the quantities of interest. So if a patient drops out, we don't try to identify their population membership. We simply use the patients that are available to us at the time of analysis to estimate the probability of belonging to a particular principal stratum. Of course, this does rely on some assumptions as well. I hope that addresses the question.
Thank you very much, Balder.
Thank you. So I think that's that the last question, Russell?
Yep, that's the last question. Yeah.
Okay, I will hand it back to Muna then.
Thank you very much, Baldur, and thank you for the great presentation and a nice case study, which shows that sometimes looking at slightly different effects is really necessary to target the question of interest. So with that being said, I'm happy to introduce our third speaker of today. We have Renji Sun, who is currently a senior mathematical statistician at CEDA of the FDA. Ranji received her PhD in biostatistics from the George Washington University, and she has a range of research interests, including equivalence, non-inferiority, and non-inferiority studies, missing data, but also causal inference. And today she will be talking to us about estimating causal effects in clinical endpoint bioequivalence studies in the presence of treatment non-compliance and missing data. So Ranji, I'm just giving you the control now, so you should receive it in a second.